Hi everyone, I want to talk about dementia treatment. Kindly check out my other presentations on dementia before now. Okay, let's go. Prepare before the onset. How could you get yourself prepared? With possible family history, then you should be getting yourself prepared that is likely going to happen. Get ahead by selecting your substitute decision maker, give your advanced directives right now, and that will be followed if in case in future you are unable to make such decisions. Family members or substitute decision makers should ask the doctor for the side effects of the medications that their loved ones are taking. The reason is that the affected individual with dementia may not be able to tell what the side effects are. So it's the responsibility of the substitute decision maker or the family member to find out so that they will know when they are getting those signs and symptoms in their loved ones. Okay, as caregivers, the first thing to address is the safety. We should address safety issues as per driving. If you have listened to my other presentations on dementia, that has been fully addressed. So I'll just mention them briefly here that driver license should be suspended when we have made a full determination that this is dementia indeed. Cooking, no more, no more. The individual cannot stay by him or herself and be cooking. If not, she will burn herself and burn the house. Can't live alone and will administer medication by assistance. Somebody must supervise, somebody must help him or her to get the medication. Wandering and getting lost, all have been fully addressed at length in my other presentations. Please check out. Okay, we can stop the individual from driving after full meeting with the affected person and family members and notify the authority that are issuing the license. Occupational changes or occupational therapy is possible to be discussed with the family and the affected people and plan for group home. That will be the better option. Plan for group home, not letting the individual live by him or herself. Or if there's other alternative whereby somebody could serve as respite staff or a family member who volunteered to be doing that, the bottom line is this individual cannot live by him or herself anymore. The retreatment might take two forms, non-pharmacological and pharmacological. The non-pharmacological interventions will start all these before the onset of the illness. Okay? And that is, we're going to make accurate diagnosis because what we're going to do when it comes to treatment might be slightly different based on the different types of dementia. For example, the way we're going to handle Alzheimer's disease is different from dementia with Lewy bodies. And multi-infarct or vascular dementia, like in Lewy bodies, we don't give haloperidol. And we have to rule out reversible causes. So those will be the non-pharmacological interventions. One, make accurate diagnosis so that the pattern of treatment will be accurate. For example, if it is Lewy bodies, no first generation antipsychotics, no haloperidol. Prevention. We can only prevent what is preventable. Modifiable risk factors in vascular and multi-infarct dementia could be prevented. For example, advise that individual to stop smoking, to decrease weight, statins, treat hypertension, and HIV prevention. That is before the full-blown. Once the history is in the family, we can start immediately. Nutrition in affected individual should be standardized. Why? Since they can't remember to tell if they're hungry or they have eaten, then the responsibility is on the part of caregivers to standardize the pattern of feeding. And that should be instituted in such a way to meet all the requirements. Dietitian could be involved, determine the type of food items to be taken, because they can't tell that they are hungry and they can't tell that they have eaten. Cognitive rehabilitation is for future benefits and maybe beneficial in future, I don't know yet. Alcohol, okay, since they cannot say that they know the quantity of alcohol they have taken or to be taken, then anyone with the history and is not yet having full-blown dementia or the situation is not that bad, then should decrease alcohol intake. But to those who are already diagnosed with dementia, then alcohol should be stopped. Okay, pharmacological interventions. Before we embark on that, we need to know some basics about that. There is no cure yet for dementia, but can delay the onset if the signs and symptoms are coming up early and the individual embarks on treatment, or the family is known for that and preventive measures are taken, the onset could be delayed. Then the level of declining in function could be delayed if, or the rate as well could be delayed if treatment is instituted on timely basis. What are we going to see that will give us impression that we are winning when it comes to treatment? The rate of cognition decline will be very slow. Many mental state examination score will be static or at least not declining, not dropping. And behavioral changes will improve by not getting worse, and the rate of pacing around with possible repeated questioning, where am I, will reduce. Then you know your medication or any form of intervention you're embarking upon is actually working. The pharmacological intervention will involve first-generation antipsychotics at a point, but we don't usually encourage that and is even contraindicated in dementia with Lewy bodies. We treat symptomatically, and insomnia will attract the use of melatonin. Memantine is pretty good, but when it's given to anyone with vascular dementia or Alzheimer's disease at 20 milligrams per oral once daily, there's going to be agitation and delusion if the individual is being treated for Alzheimer's disease. And it's not good in dementia due to Lewy bodies because of possibility of hallucination and delusion. So as good as Memantine is, we'll be careful depending on the type of dementia. That's why I say from beginning, accurate diagnosis is the hallmark. Cholinesterase inhibitors will increase the level of acetylcholine because most of the affected Alzheimer's disease patients have low level of acetylcholine. And examples here will be donepezil, rivastigmine, galantamine, and you're going to do more favor if you combine one of these, particularly donepezil, with memantine. But be careful, the type of dementia you're dealing with will give the indication whether that is going to be beneficial or detrimental. Antioxidants like vitamin A at the level of 2,000 international units per day is helpful. Selegiline is used by some, but I will personally not use it, and it is not even encouraged to be using selegiline because it is a monoamine oxidase inhibitor. Why? there are a lot of horrible side effects and, of course, dietary restrictions. We have to address agitation, but that should be done based on the protocol as a center. Redirection if it's aggressive behavior, and hospitalize if possible. Security personnel could be involved, and medications like Adderall, olanzapine, or benzodiazepine could be useful, but it depends on the type of dementia you're handling. No fixed or rigid rule as to how to get that solved because it depends on the circumstance and specific diagnosis. For example, you can't use Adderall in Lewy body's dementia. In conclusion, for now, I'm wishing the affected people, their loving family members, and the wonderful caregivers well, because it is stress on everyone involved. Thank you for listening to my presentation. Kindly subscribe so that you can get these presentations immediately they are published. Thank you.